The Kansas State School for the Blind presents KSSB Roundtable. KanLovKids Ask the Doctors, February 2025.
Dr. Krug and Dr. Lawrence are very kind to come spend some time with us this morning and allow us to put them on the hot seat. So we did not give them questions in advance. And I don't think they came with presentations prepared. So this is your challenge to see if you can stump them today. I know most of you have participated in a KanLovKids clinic in some way, shape, or form. Hopefully, yes, you should now be seeing the School for the Blind webpage. Just in case you are not sure or you want to make sure that you've got things going, I'm going to share my screen. Hopefully, yes, you should now be seeing the School for the Blind webpage. You don't need to see the meeting chat. I'll hide that. So the easiest way to find KanLovKids clinic information is to scroll all the way to the bottom of the KSSB webpage, which, if you don't know, is now kansasblind.gov. We are in the process at the requirement of the state of updating all of our webpage and all of our email addresses. You'll see more information coming. But if you put it in kssb.net, I believe it will still redirect you. But at kansasblind.gov, if you scroll all the way to the bottom, you've got an awesome picture here of Dr. Krug holding some trial frames up on a kiddo. You can just click the KanLovKids link right there, and that will bring you to our specific page, which of course is going to take a second now to open. There we go. And of course, what you're typically looking for are all of the forms and clinic information. So the button that says Forms and Clinic Information will bring you to this page with general information. So this is also great if you're working with a special education director to help explain to them what a clinic is and why we're asking districts to support this, how it's different from an eye doctor's appointment. And then you have a choice, the two red boxes here toward the top. If you want a low vision collaboration clinic, which is more like what Dr. Krug and Dr. Gerson and Dr. Seiler do, with students who are more academic and are needing access to materials, you would click the Low Vision Collaboration Clinic link. And there are actually two forms to fill out and one information letter for parents. So there's one form for teachers, one form for parents, and this information letter is for parents to read. It's also something great to send to other teachers or special ed directors to talk about the clinic. That's all you have to do. Those come through Google Forms to Rachel and I, and we take it from there. So we just need those two forms. The TVI form will ask for a recent eye doctor's report. You can upload that as a part of that process, or you can send that to us separately, whichever one works. So that's all we need for that. And then if you're coming to a Low Vision Collaboration Clinic Plus, that would be typically with Dr. Lawrence. And so for our babies or for our students who do not necessarily communicate verbally or not as academic and need a little bit different in-depth type of clinic, we do have more forms for that. The TVI form is the same. And then there's the information letter for the parents. The consent form for these clinics is different because it generates an extra doctor-to-doctor release form that goes to Dr. Lawrence's office. So if you select that you're wanting to see Dr. Lawrence, the parents will complete an extra form there that will give her release to get more information from their doctors. And then we ask for a child family history form. And when we can get to these in person, which we tried yesterday and ended up being online, we will also do the eye gaze assessment as a part of that clinic. So we have the eye gaze permission form there. So if you're coming to the Collaboration Clinic Plus, there are a few more forms for parents, but this gives us really nice background information. Does anybody have questions about that process? Any way we can help you with just knowing how to request a clinic? Stop my share so I can see everyone again. It's quiet.
Yes, I can just make one comment here. The reason the sooner we can get those release information forms, the better, because we try and get discharge summaries from the hospital, from Children's Mercy, from Wesley, and it sometimes takes a while. And if office has those, we can be, if the parent doesn't have that information, we can usually get that. And that information is really important if we're trying to make a diagnosis of CVI. So the sooner you can get those forms, the better.
Yeah, absolutely. And if the parents can just go in, it's one Google form to fill out. They should be able to do it on their phone. If they need translation, and I don't know, Melissa Schlegel, maybe you can speak to this if this worked out for you this week. There is a way in Google Forms when you go to the 3 little dots, there's a button that says translate. And if the parents need that form in a different language, Google Translate will translate the form for you. So give that a try. I think, Melissa, is that how that ended up working out this week, or did they figure something else out?
I honestly don't know. I just know that PSP texted me and said they got it done. And so
Okay.
I'm not 100% sure if they ended up doing it in Spanish through the Google Translate, or if the translator just kind of sat down with them and translated the questions. And
Okay.
I'm honestly not sure.
Okay. But give that a try, or if you need forms in other languages, let me know and I can work on that in other ways. But in theory, with all of the technology we have available to us now, hopefully that can happen with a few clicks in that process. Are there other questions just in general about clinics? How to get signed up? Who's appropriate to bring? Who's not?
Hey, Anna, can you go back to the webpage?
I can. It'll take me just a second. There you go.
On the side there, make sure you take advantage of those training videos. I don't know if any of you have, but if you have a device for a student, give the parents the link there. Really good training videos there just to go over different types of devices. So do take advantage of that.
Yeah, great point. So there are quite a few videos there and different options. Good resources available. Thank you. Good point. Okay. Well, I know most of you are here eager because you have lots of questions for Dr. Krug and Dr. Lawrence, right? So I'll open it up. If you want to put your question in the chat, if you just want to unmute and ask your question, of course, we will keep any identifying information out of our questions. So, in theory, somebody has a student who, if you need kind of specifics in that area, or maybe just general diagnosis questions. I have some idea questions written down, but I'd love to hear from you guys first. Anybody have a kickoff question for us?
Oh, I think I just had kind of an interesting situation in my clinic recently, and I saw a baby who was referred because they had ROP. They're very, very premature, and so I'm following them along as a CVI suspect, and other things that could go along with regressed ROP, and the baby's doing quite well, but the mother's blind. And it brought up some interesting things about how to support. It could have been the baby would have been blind with a blind mother, or how to support a young blind mother with a typically developing child. And I think there's a PhD paper that just came out recently looking at this, but it was kind of an interesting situation to be in. I didn't really know what to do. I mean, I went to OCCK and all that, but it's so sometimes I think what's really important, especially in the birth to 3, is how we support families. And we got some good support, so.
Okay.
I can bring up another topic. Since I get to see the older kids, they hit high school, and the question of driving always comes up. Yes. And Linda sends all those patients to me to deal with it. One of the other things I'm doing in my semi-retirement is I'm on the medical advisory board for the Division of Vehicles in Kansas. So this is the committee that reviews the medical and vision restricted licenses. And one interesting thing of note, we're seeing a few licenses coming through with the diagnosis of cortical vision impairment. And as you all know, that's kind of like our number one diagnosis now in this age group. So be real cautious, because some of those kids can have very high functioning vision. And I can relate one case that CVI patient who was older, had failed 3 times on his. He had 3 wrecks and had his license taken away 3 times, and the state grants the license, the doctor doesn't. The doctor's role is just to report the vision and any recommendations. But the 4th time he actually killed somebody, so it's not unusual. And especially if it's somebody that lives in a metropolitan area, there's a lot of things coming at you at once. So be cautious on what we tell the families about driving. And I don't have any good answers for that, other than there is one behind the wheel training program. I believe it's in Kansas City. Some of you might know about that. But yeah, be careful. I really hate having to sign off on those. I really try to get the regular hometown eye doctor involved and filling the forms out. And this goes back several years ago when there was a young patient who was denied a license his first time twice, and then the 3rd time he passed the drive test, which is a requirement most of the time, and then he went out and killed somebody. And the family of the deceased sued the state for granting the license. And then in the first of its kind, the state sued the eye doctor who was in Salina, which that's never happened before, because the state law says that we're reporting in good faith. So keep that in mind. Good faith does not stand up in court in Kansas. Other states have liability protection for who is ever reporting that. So the doctor's role is to report the vision and recommend suggestions, but the license is granted by the state. So
that's a really good topic, but I often find myself not knowing how to, most doctors, besides maybe Dr. Lawrence and yourself, know the functional side of CVI, but don't think I've ever come across an eye doctor report that explains the functional vision of CVI, which is so different for so many different kids. And I often, I've never been asked by the state for a functional vision report for a kid. I wonder how I could help.
yeah, I think communicate back with the doctor, and it's usually going to be driven by the family that, bad pun there, but they're going to drive getting the license because they want their child to be able to have some independence. And hopefully one of these days, I foresee a time when the state will actually have a license for a self-driving car for visually impaired patients. I mean, that's coming. We don't have it here yet, but the best we can do in Kansas right now is require a drive test where the state actually takes them out in a car and they have to prove that they can drive. If we look at the literature, and I've lectured on this at the ICOM symposium here a couple of years ago, there's a test called a useful field of view test, and it's done on a computer, but it's basically you're identifying a central target and then a peripheral target at the same time, and it's an age-based timed test. So it's kind of a visual field and a reaction time all in one, and it has the highest correlation for driving risk of crashes. The problem is the state doesn't require it. When I was in private practice, I had one in my office, and Dave Leverns, who was practicing in Kansas, was the one who got me on it. It's out there if you look it up. I think you can administer it online, but that's really the only way I would sign off on a license from a vision standpoint, is if I had the useful field of vision test. And I can tell you a couple just from history. Probably the person that did the best on that test, even if I compared it to a normal 30-year-old, was a young man that had albinism, and he had about 2100 vision and some nystagmus, and he had the best score on the useful field of view test of anybody ever tested, even patients with normal vision and no pathology. So it's a nice test to be able to prove that this person should be driving. It's got over 50 peer-reviewed articles written on it, and I tried to drive the state to get something like that for special licenses, but that's kind of an uphill battle because it's all driving laws are in statute. So your license is a privilege that the state grants if you can meet the statutory requirements, which at this point is better vision of 20/40 or better with or without correction in one eye at the doctor's or at the exam station. If they go to the doctor's office, they have to be better than 20/60 in one eye if it's for a Class C license. There was a person came through here a while back who that was on the review. He had a commercial license and he had one eye. So there can be some exceptions. I'm glad I didn't have to review that one, but I read some history on it. So your visually impaired students, be careful what you promise them when it comes to driving. But hopefully your local eye doctor can guide you in that way, or certainly I'm always happy to give you the steps that you have to go through to do it. I've got a kid from Abilene right now that we're going through the process. And in the state of Kansas, if you can't get a driver's license, you can drive a golf cart or an ATV. If your city allows it, you cannot cross a state or federal highway. So you can do that. And I've had patients that was the only way they could drive around town.
I also think it would be cool if we had better access to, like free access to things like Lyft and Uber for visually impaired young adults, or I don't know, something like that. That would be another option besides self-driving vehicles. But
yeah, that's a great point. And the little apps like Seeing AI, which we all love to show people because it's free. That'd be neat if they could integrate some kind of Uber link in there for the kids to use that.
Also, if you ever need us to sign a letter to the state, I would sign it to get that test you were talking about, to make that mandatory. Yep.
Okay. We're talking about it's peer-reviewed stuff, and I mean that's how we want to make the decisions. And as I've reviewed a lot of these cases, they'll go back 20 years. Once you're on a vision restriction, you have to have a vision report every year. They have to go to their eye doctor. They have to fill out the DV-135 form, send it to the state, and it's just page after page. But it kind of depends on who the vehicle director is at the time. And I've seen probably cases going back 4 or 5 different vehicle directors, and some of them are pretty lax, and some of them, most of them are pretty lax, I would say. But you can tell that they're doing what they're told to do by the state, and it's not always what we think is the best option. So.
Okay, those are good thoughts to think about. None of us really want our name on that line saying that the student can drive, right? So. All right, well, we might jump just a little bit. I know another topic that comes up fairly frequently, and Dr. Lawrence, hopefully you can speak to this a little bit, as we're seeing more and more diagnoses of CVI and recognition of students who very likely have CVI. That question always comes up of distinguishing CVI and autism. And Dr. Lawrence, I know I've heard you in clinic give good description of things that you look for to know the difference. And I just wondered if you could kind of give teachers some direction when that question comes up and somebody has a concern that, well, this student is autistic, but we don't think they see well. And what do we know? What do you suggest? Where do we start? And how do we handle that?
Oh, thank you for that question. That's $1 million question, because, as we know, kids with visual impairment can have sometimes their frustrations and their anxiety can manifest as autistic type behaviors. And also kids with autism can sometimes have behaviors that cross over and look like especially CVI or visual impairment. So trying to tweeze that out is not always easy. And I think if we think of autism spectrum more in the social, emotional, sensory area, and visual impairment, the problems with visual impairment more based on your functional vision evaluation, that's going to help a lot. We did a study in India where we went to school for kids with autism to just try and answer that question. And we did a whole battery of tests. Every child there had a diagnosis of autism spectrum disorder, various degrees. Some were verbal, some were not. And we did all of our tests, and every one of them had CVI by our testing. So I think as we go forward, those kids who have autism diagnosis, we have to look super carefully at their visual function and look at what caused the autism. Is it, we don't know. Is it they have a genetic disorder that may have some crossovers with, we saw one boy yesterday who had a genetic difference that it's known has CVI, it's known they have autism, so they can have the two together. So they can definitely coexist. But I really feel like the eye gaze helps, and then your functional visual assessment is very, very helpful. So those kids with questions, I think, just do that. And remember, their eye movements. There's a difference between looking away in a kid with autism who may look at the fixation paddle 2 seconds and hates it and looks away, versus a child with CVI who is really having difficulties with the vision and the sight. Visual field cuts can really help if you can actually get a visual field difference that can help point more towards CVI. And of course, the medical history. If they had a medical history of extreme prematurity, guess what? About 14% of those kids are going to have autism spectrum disorder, as well as possible visual impairment and CVI. So, but the medical history can be really, really helpful if there's a definite brain injury, prenatal, perinatal, or postnatal with hypoxia. Again, many of those kids can also develop cerebral palsy and autism spectrum also. We're seeing in our kids with Down syndrome now, 40% of them have CVI. So I'm now considering all of my kids with Down syndrome to be CVI suspects, because I think 40% is a lot. And we have a special group called the Down Syndrome Medical Interest Group / CVI group, who we're actually meeting today. And we have a Kansas mom who's a special educator who has 2 kids with CVI, 1 with Down, and then 1 girl with Down without CVI. And we're going to be talking about that today. It's a new group. It's only 6 months old, but we're looking at all the evidence behind that. So with autism spectrum and CVI, we really need to, have a little more evidence as far as how to make that distinction. But I don't think anybody can give you an answer on that. But ask me some questions and maybe we can figure it out.
I got a question for you, Linda.
Yeah.
Some of the literature, at least in the optometry literature in autism, they talk about central and peripheral vision disintegration. Do you have any thoughts on that? Where, they have this wandering gaze, you never know exactly where they're looking, and they have that wandering gaze. And they theorize that the brain is not integrating the peripheral vision with the central vision. And there's been some evidence where they prescribe yoke prism and things like that to just kind of really upset their balance. That sometimes that can, it's more anecdotal, I think. I've tried it a couple of times, but do you have any thoughts on that?
You mean in kids with autism?
Yes.
Yeah. The yoke prisms, I've tried them too, and it's like, well, we've tried everything else. What about this? I've tried them in kids with field defects, and it's hard to sometimes know if it's just they're improving because developmentally they're going to get better, or if it really helps. There was one boy I met at a conference, I can't remember where it was. He's a Kansas boy who really very verbal and has both CVI and autism spectrum, and said the prisms are his lifeline. They tried stopping the prisms, and it just, because it's like, are they working or not working? They stopped it and he couldn't function. So he could say, yeah, they really helped me. But unfortunately, a lot of our kids can't vocalize that it makes a difference. So we have to do it by observation. But, there is a lot of various things out there with prisms and different interventions. And, there's just not a lot of evidence behind anything. That's the problem. So I think I always put it back to you guys, because you're the ones who see the kid in the classroom, you're doing the functional vision evaluation. You're looking at their academics with their whole team. And, when you think, well, maybe this intervention is going to help, do it and then keep the data, track it. We don't want to just do an intervention, say, well, maybe it'll work, maybe it won't, keep data on it. So if it is working, we know to go forward with that intervention, whether it be towards the behavior and autism or towards the visual impairment. But I think one of the problems we have is that the outer or the overall diagnosis can often mask the visual impairment. So if you have a child with autism spectrum, everybody might say, well, that's because he has autism. That's what we see. Or they have cerebral palsy. Well, they do that because they have cerebral palsy, or they have Down syndrome. Well, they do that because they have Down syndrome. And I think if we consider all of those group of kids with neurodevelopmental disabilities to possibly have a CVI component, and just be suspicious. It doesn't mean every kid needs to be served. It means, just keep that high index of suspicion and try and look through it's because they have this diagnosis, they're acting like that. It could be hidden CVI. And then we're directing towards the wrong thing, or not giving them the proper, help that they could use to be successful.
Describe a little bit why, and I know, Linda, we worked together with a student who we tried prisms with, and can you explain what it is you're doing? Like in that situation, it was a lower field. He was always looking down. And so you tried the prisms, but can you explain a little bit when you do try them, why you try and what you're looking for?
Well, there's two different things. One is like what Dr. Krug said, you disrupt their system and kind of reset is one theory. And then the other one is in a field deficit that you actually move the image. But, it's hard to measure if we really move the image into an area where they can see better. It's just been a really interesting thing. So sometimes I'll do that in my Birth to 3 program, because the classes are free. We can just try it. I just don't have a lot of experience. I would say probably most ophthalmologists and optometrists have very little experience with that, with using the yoke prisms. So, but, if you see that sometime, it's not something to just say, oh, well, why are they doing that? There may be a reason, like we've tried everything else, let's try this. So, what you're looking for is improvement in everything, in their mobility, in their access to information on the screen or on their paper. And, the kids I've had with lower field defects, we've tried it on, we're just hoping that it's going to move that lower image up into more of their seeing field, so they don't have to do so much of a head tilt. But it's not an evidence-based intervention at this point.
Yeah, we've used it some on like hemianoptic patients where they have a field loss to one side. And you may have seen these kids, they'll have what we call Fresnel prism. It's the plastic prism that we can stick on the glasses. And as Dr. Lawrence talked, if you have a right hemianopsy where they'd have a field loss to the right, you put the prism on that side and you shift the information from the right field over to the left. And that works. when you see the prism diopters on the prism, you have to go pretty high. For instance, a 30 prism diopter prism is going to give you about 15 degrees more field of view. So you divide the prism in half to get how many degrees of field. And if they have a restricted field, you want to at least give them a little peripheral vision on each side if you can. So I've been most successful with that if it's a hemianopsia, just to put it on the blind side. If it's a right hemianopsia, I just put it on the right ones, and it's more like a rear view mirror. Basically, one thing they complain about is things sneak up on them. So if you have a right hemianopsia and somebody walks up on their side, it startles them because they don't see it there. It basically gives them a few more degrees of just movement, being able to see movement out to the side, like that. And if the kid, and then you have to talk about, are they binocular and things like that. And we have tests we can do to see if they are using both eyes together, but that's more your central vision. If you have a kid that, one eye is really poor acuity wise, and the other one is good, they're likely not going to be using both eyes together. And there are different levels that you could talk about. If there's more than about a 3 or 4 line difference between the right eye and the left eye, they probably aren't going to be using eyes together. They'd be what we call biocular, where they can use both eyes, but they just don't have that overlap where they get depth perception and things like that.
So that, yeah, the hemianopias too, sometimes there can be a lot of compensation with just a slight face turn and gaze. So in a sense, they're doing what a prism would do. So if you see these kids, it'll be just the slightest face turn and eye gaze. And O&M is important too, because, obviously if they're successful in O&M and they can, access that field appropriately, then we don't, we work with optics and we work with, functional things like O&M. So every child's going to be really different too. So we don't want to sound like, oh, this is great, we do yoke prisms. It's like one of those stretches of, yeah, we're having trouble with everything. We're having trouble with O&M. We're, the kid's just not being successful. And then it'd be an additional thing to maybe try.
Mm-hmm. Yeah, and they will adapt, or they'll habituate to the prism, so it'll seem to work for a little bit to make them aware. And so I think for O&M, it's important if one of us gives you a prescription to have some Fresnel prism to expand the field, practice with the student with and without the prism on if you can, to kind of demonstrate, walk down a hall or something and they can't see the wall to the right or whatever, and you put the prism on and, oh yeah, I can tell that the wall's there. But like Linda said, they're moving their heads. So what we want to try to do is give them a head start into learning to gaze into the restricted field side. So there's a lot going on there. And, look at your students when you're doing your functional assessment. Just sit right in front of them and, say, how do you see me the best? And it's amazing what you can pick up just with a slight head turn. And that's gonna tell you something that they're not seeing to one side.
And this is why when we do the eye gaze, it's really helpful to do the recording of the face of the child, because often you'll see in the kids with CVI, they'll do a little face turn and eye gaze, and then you get, okay, I bet you there may be more visual field loss there that a standard visual field could pick up, but they're compensating, and with that compensation, they can actually perform pretty well. So what I look at is that face turn. It's not like, oh, they access the screen perfectly. It's like, yeah, they did, but they're already doing some compensatory things for it. And, if it's a slight face turn gaze, that's fine. But if they're like this or like this, that's not going to be a very, very good position. That's when we would look back at things like prisms or eye muscle surgery, if there's indication for that, to put the head at least in a more central position.
if you're doing visual acuity tests, I'm old school. I like doing the visual acuity test myself because many times you'll pick up a field loss because they'll say you're using the logmar chart and there's 5 letters on each line, and they'll say they miss the first letter on every line. Well, there's probably something going on to the left, or as you're reading across, they can read the whole line, but they don't see the last letter on the chart on the right side. So those can be clues that something's going on. So watch for that. Every little test you do, you want to know what they can see, but you want to see how much they can see, and just simple tests you can do to look for stuff like that.
Those are really good pointers. I was thinking about the field test as you guys were talking about that, and my understanding is really it's the choices there are like confrontation fields or maybe like a Goldman. Some of the new technology that's out that does heat maps, is that recognized in your field as sort of a formal field test, or is that still in the what they would call experimental, not tested stages for young children?
That's the gaze test, isn't it, Linda? The heat map?
Yeah, if you're talking about the eye gaze, that's not a visual field test. It's a functional, it's a measurement of where the child's looking on the screen. So, and it's binocular. So we don't consider it a visual field test. That's actually on the consent form, because we want to be sure that, everybody understands we're looking at functional vision of this child and not specific visual field. A visual field would typically, you can do binocular, but typically you cover one eye at a time. And the Goldman's kind of an older test, but it's really good. We don't have a lot of those anymore. But the Humphrey is more of an automatic. There's different automatic ones, but I don't know about a heat map one. Do you know?
I was just thinking for young children, it's always so hard because they maybe aren't very good at doing a confrontation field. They won't look forward, and how do you really test a field loss in a very young child when they're not able to do that formal test? I'm just trying to think, like, how do we get that information? How do you get that information? Is it just kind of anecdotal from your evaluations, or?
Yeah, you have to have tricks. And, there's a lot. The confrontations are good, but you have to be really careful with confrontation, because if they pick it up, they're going to look at it and then you're going to interpret that. There's like a Leia wand that I actually have. I don't use that much because for me, I'm way more interested in the overall function of the child than the specific visual field deficit. To me, that's a medical concern, and what I'm more interested in is how the child's using their vision in a functional way, and that's why we developed the eye gaze. So that gives you the heat map, but that's both eyes, and that's the child can do whatever they want. They can turn their head, they can tilt, they can move to the side of the chair, and we record all that so we know how they're already using compensation. We can kind of, when we look at an MRI scan or a CAT scan and we know where the lesion is in the brain, we can predict where a visual field loss might be too. So we would know to look, like if they had a stroke on the right side, we're going to be looking really hard at that left side for neglect or a visual field loss. If they have PVL, from prematurity, we're going to be really looking at that inferior field, because we know from experience that PVL is highly associated with inferior visual field deficits. So a lot of that is interpretation of that medical record. And then you can be more specific in testing that area. Like if I know they have PVL, I'm going to really be watching and keeping their head up and trying to really get that lower field. Whereas, if they don't, I may not be so specific. And the same goes with a tumor or a heminopia, known heminopia, So we use confrontation. We can use the eye gaze as a functional test of the binocular vision. So it doesn't tell you if they have for certain a heminopia or not, but it would tell you if they're compensating or not compensating for a visual field loss, which is basically what you want to know. What's their compensation? And then when they're older, we can do an actual visual field. There's not any good test out there for babies. There's been some that they've worked on. Louisa Mayer, I know, who worked with Barry Cran up at Perkins, had this fabulous visual field test where you put the little kid in there. There was all these games playing. She brought never went past their clinic. That's the only place it ever was. It was not commercial. And why? Because there's no money. Nobody does visual fields on babies, unless it's in a research setting. So I think if you look at your medical history, be suspicious, and then do specific testing in that field.
Thank you.
I like doing a confrontation. I don't work with as younger kids as Linda does, but I was always taught confrontation. You want to have simultaneous, if you just bring a finger or object in from one side, they're going to look at it, but try to do both sides at the same time, and you don't tell them which one you're moving. And you just want to look for the eye movement is what I do. They're especially if they're not verbal, but you just keep bringing in the object until you see them turn that way or turn their eye that way. They likely see it. I think there's some instrumentation in the pipeline that will help. Some of it's with VR type goggles that have visual field. A lot of offices are going to that kind of work, but to actually have an electrodiagnostic capability to having a visual field where you don't have to do anything, it's gonna present a stimulus in the field of vision, and then it's reading for the cortical impulse going back to the visual cortex. And so they are working on stuff like that where you can have a visual field where you don't have to respond, and it's going to record seeing and non-seeing areas. So that's exciting. And if they can do it with a VR type headset, it probably wouldn't be all that expensive.
So interesting. Can I ask a different question? Okay. All right. In our field, we often get a lot of questions about vision therapy. And our standard response is that we don't do vision therapy because we're teachers and it's not really in our scope of practice. And we, work on accommodations and things related to the education. But what can families that we work with, what could they expect, or what have they been told about how a behavioral optometrist maybe is trained to do vision therapy, and what does that look like on the family side and on the medical side, and what do we need to know about that related to their education?
Do you want to go first, Linda? You want me to?
Yeah, it's always kind of a hot topic. Yeah. But if you look actually from the ophthalmologist standpoint, it's not considered to be helpful, and it's not evidence-based. So having said that, I know there are people who can be helped by vision therapy. My approach is that I want to treat the whole person, and that just working on the vision isn't treating the whole person. So in the rest of the world, they call what you do vision therapy, and what I do vision therapy. And I actually have patients who come in and call me a vision therapist from Kansas. So there's a lot of confusion about the actual term vision therapy. And people get confused because they have occupational therapists, they have physical therapists, they have speech therapists. And so you're the vision therapist because you're helping the vision. So many people use that term. It's inappropriate, but they use it because that's what they're used to. They're used to getting therapy. So I think exactly what you say is, I'm not a vision therapist, I'm a teacher, and we're looking at different things. And I say the same thing. I say I'm not a vision therapist. I'm looking at the whole child, and we don't just treat vision. We treat the whole child and the development of the child, with vision as being, the main input. So there are actually on the APOS and American Academy websites statements that talk about vision therapy. So if you want to go further, but it doesn't mean that some people aren't helped. And why? I can tell you a story of my nephew. He had an exotropia when he was young. He had microcephaly, some other developmental delays, and I told his mom and dad, his dad's a doctor, that I wanted him to see a pediatric ophthalmologist in Houston when they got back. So instead, he went to a vision therapist and did vision therapy for 2 years. It was very expensive, but he loved it. And so I asked him, I said, what do they do? And he says, well, I get somebody just gives me a lot of attention for 30 minutes every day. so sometimes that, and I think that really actually benefited him, whether anything to do with his vision or not. So, there is some direct attention to the child and some things that sometimes good things can come out of it. So I don't know, Kendall, your turn.
Yep. Well, coming from a optometry standpoint, we're all trained in how to do it, and I came to a awakening when I did one of my externships at Children's Mercy Hospital back in like 1984, and Gerhard Siebes was the pediatric ophthalmologist head there, and his wife was an optometrist. So it was an interesting play on what we can do. She actually was the person that got me interested in doing low vision. So, but we actually were doing a study at his office, which I assume he published at some point. He's now deceased, but looking at the main types of vision muscle disorders, where you got esotropia or esophoria, where the eyes turn in. We have exophoria or exotropia, where they turn out. And the conclusion of the study that was done through his office in Children's Mercy showed vision therapy was effective for exophoria, where your eyes turn out, where you can improve their convergence efficiency, but for esotropia, esophoria, it was not proven effective. So I've that stuck with me my whole career. Now, if you have a kid with amblyopia, that's where one eye doesn't see as good as the other. So, you determine if there's a refractive component, and then if there's an accommodative component, and then these are the cases where we patch the eye, the good eye, to force them to use the bad eye. I think there's probably some vision therapy during that type of activity where you're trying to stimulate the weaker eye to see better, and then when you bring the other eyes back together. But I agree with Linda. There's not a whole lot out there that proves vision therapy is really effective that we can point to, other than just case by case basis. And a lot of those is they just needed an eye exam to figure out what the problem was, and going from there. But usually these are probably not visually impaired. They may have, usually it's amblyopia or oculomotor dysfunction where they can't read well, jerky eye muscles and stuff like that. So, and I think optometry's gone more to vision rehabilitation, has now become a catch-all for vision therapy and low vision. They've kind of, at least at the national level, they throw the term vision rehabilitation around more.
Hmm.
And the other way to look at it, or if you're trying to explain it to a parent, insurance doesn't pay for it. And so I think if there was a lot of peer-reviewed evidence that it was effective, I think insurance is going to pay for it. And in very few cases, at least Blue Cross doesn't pay for vision therapy, and it can be sessions and sessions and thousands of dollars to do it. And I feel my profession is kind of hopefully not preying on parents that they want to give their kid every chance. So I'm sure there's probably some of that goes on, but I also have some colleagues that do very well at it and claim good success.
There's, that we have through the NIH, I hope we still have it, a group called PDIG, which is a group of pediatric ophthalmologists and pediatric optometrists that do continual research in this area too. So it's not like, optometry's out here and ophthalmology's out here. We're always working together, especially on things like amblyopia treatment and, myopia and vision or orthoptic or vision therapy, and what's evidence-based and what isn't. So I think, that's something important to know. It's not just like, they believe that. And it's not like we are all looking at evidence together to try and figure out. I mean, we would love it if some of that stuff worked, and with the insurance not covering it, it can be very, very costly to a family. And one of the things I've had patients come in and see me after they maybe went for a month. They said, we just can't afford this and we feel so bad. And so they feel guilty because they can't lay out that money for their child. And so I have to, we're very careful about what we say, but usually it's we can find a way around that, because we don't want them to feel like they didn't do everything that, like Kendall said, everything they could do to help their child.
I'll occasionally get a call from the Lion Sight Foundation that a parent has contacted them for funding for vision therapy. And I kind of have to step back and say, I don't think I don't think you want to pay for that. It would start a slippery slope of things. One thing I might ask you, Linda, while we're here is, we see these low vision patients, students, that, they have reduced vision in each eye. Is there a good way to determine, just in your opinion, how much of that could be amblyopia? And I know it will probably vary by condition, but if it looks like they have a strong tendency for one eye, and maybe they have a retina condition, but surely can be an amblyopia component in there too.
Oh yeah, anytime we just saw a girl yesterday, she had a mild pallor in one nerve and had an intermittent esotropia and was not being patched. I'm a big patcher. I mean, amblyopia can overlie everything from super high refractive errors if the child doesn't wear their glasses and they have a lot of astigmatism or a lot of hyperopia, or they can actually develop deprivational amblyopia in one or both eyes. If there's any asymmetry in the eyes, whether it's prescription, an eyelid droop, facial asymmetry, I always look at those kids for amblyopia in at least the one eye. Even we have a high association of amblyopia with nasolacrimal duct obstructions, which is a weird association, but it's something to do with the asymmetry. So kids who have asymmetry, kids who have strabismus, or kids who have high refractive errors, we look very closely for amblyopia. Also, other eye diseases, like if you have a cataract in one eye, you'll develop amblyopia in that eye, significant if it's not treated. So they can have a great surgery, and if they don't get treatment for amblyopia, it doesn't really matter. They're not going to see. So I'm always amazed at how much we do get back and how much we don't get back with eye patching. A lot of it has to do with patient compliance and parent compliance. And I had one time a little boy look at me and look at his mother, and when I was trying to explain why he wasn't seeing out of the eye, because despite years of them coming in and me emphasizing the patching, they didn't do it. And he looked at his mother and said, "Why did you make me blind?" And that really hit me that, and I try and tell parents that eye patching, it's like taking a medicine. This is a medical treatment, and no, your child is not going to like it. And so when they come in and say, "Well, he doesn't like it," I'm like, "Sorry, you're just going to have to figure it out with him. Don't make it a punishment, make it something fun." And but amblyopia is preventable blindness in many, many, many cases. And if we don't get that, the brain needs that continuous input from birth into the occipital cortex to develop. And if it doesn't, you get brain damage. Basically, you get poor development. There was a very interesting talk when we were looking at the definition of CVI about whether amblyopia represents CVI, because it is brain-based visual impairment because the brain's not developing. But they didn't want to include that. But just think of it like that. And with patching, you could potentially get that brain development in that area to save the vision. It's really very case by case. Kids with amblyopia are all different to treat. But yeah, we should. Sometimes I'll have you guys see, amblyopia. If you have poor vision in one eye, technically they're not blind or visually impaired. But if we take a child who we're patching for amblyopia, say they're 20/200 in one eye and 20/20 in the other eye, and we're patching their 20/20 eye, guess what? We're making a seeing child blind. So, if we have to do that as a medical treatment, then sometimes I'll ask for them to have you guys come in, because during the time that child's patched, he is going to be legally blind. It's kind of a way to think about it. And so it's a really difficult, amblyopia treatment is difficult. We also have an alternative, and that's atropine drops, and atropine dilates the pupil and blurs out the vision. So we put a drop usually a couple times a week in the stronger eye, so it blurs it out, and that can force them also to develop those pathways in the poor seeing eye.
I have a quick question on patches. I just saw a little guy the other day, and they weren't using the adhesive kind, but it was a little cloth that slipped over the glasses. Is that perfectly fine?
Yeah, you mainly have to be sure they're not cheating. And
I know.
No, the patch, sometimes their skin's so sensitive but if it covers like nasally and temporally, then that's okay. And we have a little patch kit in our office we give to the parents, and so they can try different things to see what their child, if they have glasses, sometimes that'll work. You don't just put a patch on the glass usually, because then they can look around it. But the cloth ones that go from here and then all the way out to the side do work pretty well.
Okay, thank you.
One last question on that, and then we're going to need to wrap up. You talked about in that situation where one eye is maybe 2200, the good eye is fine, but we need to patch it to encourage the vision in the poorer eye. Do you ever recommend certain times of day to patch or not to patch? Thinking like a preschool student who's in school 3 hours a day, and the only time that they can manage to do the patching is while they're in preschool.
Yeah, that's a good question, because every child's so different, and I have parents that there's no way they're going to patch that child. Right. They're just not going to. And so sometimes we recruit the school to do the patching. But the preference would be after school, when they're doing something, of course, not taking a nap. And I usually tell the parents that make it a fun time. What do they like to do? What's a treat for them? Like maybe it's screen time, or maybe it's a movie, or maybe it's doing puzzles. And I say, do it then, and make it a fun game time, like, okay, it's patch time and you get to watch your videos or whatever it is, and try and make it pleasant. It just needs to be when they're using their vision. And also safety can be a real big concern. So if you have that child that's going to be 2200 with the patch, you better not send them out in the yard to climb trees. And I always emphasize that to the parents, that safety is important.
Mm-hmm. Do you have a recommendation? I know I was always taught that if the child was 5 years old, you shouldn't patch more than 5 days in a row. And if they're 7 years old, no more than 7 days in a row, to prevent, vision decrease in the better eye. And then if you send them home, you got to say at least 6 hours a day. That can be at home, 5 days a week, 7 days a week. What are your thoughts?
Yeah, there's, if you look at the pediatric studies, there's a lot of research on this, but there's also real life. And if the vision's really poor, we would like at least 6 hours a day. Usually my starting prescription is 2 to 6 hours a day. Go for 6, get 2, because it's just unrealistic in most cases to think that family's going to patch the eye 6 hours a day. If they can do 2, and I think a lot of our studies, they look at compliance, they look at all that, but when you're in a real life practice, it's way different than when you're in a study protocol. So, and we just do every day. There's no, and I check them back frequently. I also send eye charts home with parents to check, and it's really a very hard thing for parents and children to comply with eye patching. I usually patch until I don't see any improvement. So I'll patch, and then if there's no improvement from each time, then I'll probably say, let's try 3 more months, and then if there's no improvement, we're going to stop. And we try and check acuities very early. You guys know, if you've been in my office, we start at, even a year having them play the Leia puzzle. A lot of times we can get an acuity by 2. And that can really guide your amblyopia therapy. A lot of ophthalmologists will just use fix and follow, and that's really not good enough. We need that acuity as soon as we can. So, say if they're you're looking for 2 lines of difference between the eyes also. The other thing to remember is that patching does not straighten the eye. Okay, so sometimes improvement in the vision might help with straightening the eye, but the eye turn is usually not going to improve with just patching. So the eye may be eye turn can cause amblyopia, and amblyopia can cause eye turning. So, we also have to figure out what's what here. And often we'll have to treat the amblyopia and then still go ahead with surgery to straighten the eye. I always want to be real clear with parents, because they'll think, oh, well, the eye's turning, let's just patch it. It's like, no, the vision's good. We have to do surgery for that, or be sure they're in the right glasses or whatever. And always know what the glasses are for. Are the glasses to straighten the eye? Are the glasses to prevent amblyopia, because there's a difference? Are the glasses to see distance? And you should always understand, when you have a student who's wearing glasses, why are they wearing glasses? What's the purpose? Because again, you want to support the teachers and the parents with that.
Dr. Krug, Dr. Lawrence, thank you very much. And I also know they are very generous with their time. If you ever have a question that you didn't get answered today, and we need to send it on to them to get input, we can certainly do that. So don't hesitate to reach out, and we'll see what we can do to get you help. So thank you, everyone.
The logo for the Kansas State School for the Blind, a flying blue eagle in the center of a red and yellow sunflower.